Today's topic is procedural errors. So, a clinician may face unwanted situations during the root canal treatment which can affect the prognosis of the endodontic therapy. So, these procedural errors are termed as endodontic mishaps. So, accurate diagnosis, proper case selection, and adherence to the basic principles of the endodontic therapy may prevent the occurrence of the procedural accidents. So, if suppose any endodontic mishap occurred, then inform the patient about the incidents and the nature of the mishap and the procedures to correct it and alternative treatment options and the prognosis of the affected tooth. So, in that, we'll see about the sequencing procedural errors. First and foremost is inadequately cleaned and shaped root canal systems. So the main objective of the cleaning and shaping is to remove the pulp, tissue, debris, bacteria and to shape the canal for obturations. So errors during this cleaning and shaping procedures includes the loss of working length. This occurs during cleaning and shaping and it's a common procedural errors. So it is noted only on the master cone radiograph or when the master apical file is short of the established working length. So what is the etiology of it? So secondary to the other endodontic procedural errors like blockage, ledge formation, fractured instruments, or it may be due to the increase in the file size rapidly without following the sequence, or it may occur due to the accumulation of dentin debris in the apical third of the canal. So, how do we prevent it? So, the prevention is to use a sound and reproducible reference points and pre-curve all the instruments for use in the curved canals and use the directional instrument stoppers. And copious irrigation and recapitulation throughout the cleaning and shaping procedure helps in avoiding the loss of working length. And also use a sequential file size. So next we'll go for the canal blockage. A blockage is obstruction in a previously patent canal system that prevents the access to the apical constriction or the apical stop. The etiology is maybe due to the packed dentinal chips or the tissue debris, cotton pillars or the restorative materials. So, and if suppose the tip of the instrument is also used wider in the canal than the canal diameter, it also causes the canal blockage. So how do we treat it? If suppose the canal blockage occurs, place the amount of the EDTA lubricant on the fine instrument and introduce into the canal and use a gentle watch winding motion so that along with a copious irrigation to remove the dentinal chips. How do we prevent it? It can be prevented by removing all the caries, unsupported tooth structure restorations before completion of the access cavity preparation. And there should be a straight line access to the canal apex. That's how we can prevent the canal blockage. Now we'll see the ledge formation. So ledge is an artificially created deviation of the root canal wall which prevents an endodontic instrument to establish the working length in an otherwise patent canal. So the etiology may be due to that by forcing the straight instrument short of the working length in a curved canal, or by rotating the file at a working length causes the deviation from the natural canal pathway and the straightening of the canal and creation of the ledge in the dentinal wall, or also by the rapid advancement in the file sizes or skipping the file sizes. So, how do we identify it? One and first and the foremost is the loss of tactile sensation at the tip of the instrument, and if we see the file, if we have this loose feeling instead of binding at the apex. So tactile perception is very important. When in doubt, we can go for the radiograph. So in the radiograph, it is able to help to negotiate the ledge by choosing a smaller number of files, usually number 10 to 15, and give a small bend at the tip of the instrument. That helps a lot. So penetrate the file carefully into the canal with that bend, and once the tip of the file is apical to the ledge, it is removed in and out of the canal utilizing the ultra short push and pull movements. Okay, then when the file moves freely, it may be turned clockwise upon withdrawal to rasp and reduce, smooth, or eliminate the ledge. That's how ledge is bypassed. Okay, how do we prevent it? Use a stainless steel patency file to determine the canal curvature, and accurate evaluation of the radiograph and the tooth anatomy, and pre-curving the instrument for the curved canal with the use of the flexible NITI files helps in preventing the ledge formation. Okay, now we'll see the missed canal. Missed canal can contribute for the endodontic failure because it holds the tissue debris, bacteria, and other irritants. So, this may occur due to the lack of thorough knowledge of the root canal anatomy and its variants. So, the missed canal can be detected through the radiographs or by use of the magnifying loops or by the use of the ultrasonics or the accurate access cavity preparation. So prevention is that taking the good radiograph at different horizontal angulations with good illumination and magnification with accurate axis opening will prevent the missed canal formation. If you see, next one would be the instrument separation. Instrument separation is common and frustrating problem in endodontic treatments which occur due to the improper or overuse of instruments, especially while working in curved, narrow, or tortuous canals. So, it may be occur due to the overuse of the dull or damaged instrument or by the variation of the normal root canal anatomy. So, how do we bypass it? So, the key to the bypass is that first and foremost, we should be able to manage it by passing the number 6 and 8 file with a straight line axis. And to remove the separated file, expose it first. So it can be done by modified Gates-Glidden drills, by modifying it by removing its bottom half and thus creating the flat surface. So here with the Gates-Glidden, perform the crown down technique and use this modified Gates-Glidden to enlarge the canal to a point where the instrument is located. This is the way the platform is created, which enables to visualize the broken fragment. Thereafter, the small tipped ultrasonic instrument is used in a counterclockwise motion to loosen the file. And irrigation combined with ultrasonics can frequently flush the file out. So, for instrument retrieval, we have various special instruments such as the measurement kit, endo extractor, instrument removal system, wire loop technique, and the surgical removal of the broken instrument. So, in that, we'll see about the instrument removal system. In this technique, we use the microtubes which has a bevel of 45 degrees and a handle. And here, after gaining the straight line access to the canal, select a microtube and insert into the canal. After the guide the head of the separated instrument into the lumen of the microtube. Then place the inserted wedge through the open end of the microtube till it comes in contact with the separated instrument. And turn the insert wedge clockwise to engage the instrument. Then finally move the microtube out of the canal to retrieve the separated instrument. That's how this technique is used. If you see wire loop technique, it consists of the burrs, ultrasonic tips and loop devices for removal of the broken instruments. So before removal of the fractured instruments, the canal should be enlarged so as to gain the straight line access and exposure of the instrument. For this, the gates clearance drill or greater taper files can also be used. So once the file is exposed, remove it using the loop device. So that's how the instrument retrieval procedures are done. So prevention for the instrument retrieval is that examine each instrument before placing it to the canal. Always discard the instrument when there is a bending of instruments, corrosion of instruments, unwinding of the flutes, or excessive heating of the instruments or dullness of the instrument. By this, you have to identify the file and then discard it. Now we'll see the deviations from the normal canal anatomy. In that, zipping is nothing but the transposition of the apical portion of the canal due to the improper shaping technique. This gives the shape of hourglass or the foraminal rib or the teardrop shape. And elbow is nothing but when the file is rotated in the curved canal, a biomechanical defect elbow is formed coronal to the elliptically shaped apical seat. This is the narrowest portion of the canal. And in such cases, you just have to pre-curve the files and use the incremental filing technique with the flexible files and remove the flutes of the file at certain areas. That's how you can prevent the formation of the elbow and the zipping. Now we'll see the stripping. Stripping is lateral perforation caused by over-instrumentation through a thin wall in the root, and is most likely to happen on the inside or the concave wall of a curved canal, such as a distal wall of the mesial roots in the mandibular first molars. And this can be detected by the sudden appearance of the hemorrhage in the previously dry or the sudden complaint of pain by the patient. How do we repair it? Here, what happens is that successful repair of the stripping relies upon the adequate sealing of that area. The most important and the biocompatible material for such sealing is the mineral trioxide aggregate. And how do you prevent it? By the use of the pre-curved files for the curved canals or the use of the modified files for the curved canals. And also use the anti-curvature filing so that the pressure is applied more on the tooth structure away from the direction of the root curvature. So, next we'll see about the inadequate canal preparation. That is the over-instrumentation, in that excessive instrumentation beyond the apical constriction will violate the periodontal ligament and alveolar bone. This may lead to the pain and discomfort for the patient. So how do we check that? Because the over-instrumentation is recognized when the hemorrhage is evident and in the apical portion of the canal with or without the patient discomfort, and the tactile resistance of the boundaries of the canal space is lost, and it can be confirmed by taking the radiograph and by inserting the paper point in the canal. So the treatment is to re-establish the working length and carefully obturating the canal to prevent the exclusion of the filling beyond the apex. Or the next is the over preparation. It is the excessive removal of the tooth structure in a mesiodistal and the buccolingual directions. So excessive canal flaring increases the chances of the stripping and the perforations. So these overprepared canals are potentially weaker and subjected to the fracture during compaction and the restorative procedures. And the underpreparation is the failure to remove the pulp tissue, dentinal debris, and the microorganisms from the root canals. Sometimes the canal system is inadequately shaped, which prevents the three-dimensional obturation of the root canals. So, for that reason, the adequate and accurate access cavity should be always prepared with the knowledge of the canal anatomy and the tooth anatomy. Now we'll see about the perforation. Perforation is defined as a mechanical or the pathological communication between the root canal system and the external tooth surface. It can be at the cervical level, midroot level, or the apical level. The cervical canal perforation occurs while locating the canal orifice or flaring the coronal third. There would be a sudden appearance of the blood from the canal, which is a sign of the perforation. And the midroot perforations occurs due to the over-instrumentation and over-preparation of the thin walls of the root. And the sudden appearance of the bleeding is a pathognomic feature of this perforation. And the apical root perforation occurs when the instrument goes beyond the confines of the root canal by overuse of the chelating agents along the straight lines or by the use of the stiffer larger instruments. And how do we manage is that we just take the radiograph and then we go for the treatment options. So this is the case in which the perforation repair in the mandibular left first molar is done. Here is the preoperative radiograph, and the radiograph is showing the focal perforation here. So after the perforation repair with amalgam is the third radiograph. Then you can see the master cone and the radiograph after the obturation. So always seal the perforation with a biocompatible material so that there would be no seepage of the fluid inside and outside. Okay. Next we'll see about the other errors such as the underfilling or the overfilling, which are related to the obturation. Underfilling or incompletely filled root canals are about greater than 2 mm short of the radiographic apex. This may occur due to the inaccurate working length determination or inadequate irrigation and the recapitulation during the BMP, which can lead to the accumulation of the dentinal chips and the tissue debris, which may lead to the canal blockage. Here, inadequate removal of the infected necrotic tissue in the apical portion of the root canal results in the persistent bacterial infection, thus initiation or perpetuation of the existing periapical pathosis may result. This can be prevented by having a straight line access to the apex or pre-curving the files before using the curved canals, or copious irrigation and recapitulation of the canal and attaining the apical patency by using the files in a sequential manner. And the overfilling of the root canals is filling greater than 2 mm beyond the radiographic apex. So, the over-instrumentation often precedes overfilling, which poses the risk of forcing the infected root contents into the periradicular tissues, thereby impairing the healing process. This may result in the formation of the biofilms also. So this has to be reduced by having the correct working length. Next we will see about the vertical root fracture. This can occur at any phase of the root canal treatment. It results from the wedging forces within the canal, and these excessive forces exceed the binding strength of the existing dentin, causing the fatigue and the fracture. This is usually seen in a facial-lingual plane, and the sudden crunching sound accompanied by the pain, which is a pathognomic sign of the root fracture. So, the main prevention for the root fracture is that avoid weakening of the canal wall and minimize the internal wedging forces, and also avoid the over preparation of the canal and use the less tapered and the more flexible compacting instruments. So this is brief about the procedural accidents or the errors occur during the endodontic treatment.